So I have no disclosure on this. Just to share our experience dealing with a very complex adult congenital heart disease. So at the beginning, I would like to say that adult patient with congenital heart disease is actually not a big child. So you need to think differently and uniquely in order to tackle with these kind of issues. So let me start with the common lesions with complex anatomy or physiology. So let's start with just PDA. So you may see that this ductus is not very easy to see, right, by angiography. We not really understand the anatomy. We not really understand the morphology, and also the patient usually has a high pressure of the pulmonary artery. And we need a lot of shots, contrast media, in order to get delineate the good picture. So this is always happen when we deal with a large PDA in adult patient. So it's very difficult to decide, whether it's justified to close or not, and how you're going to use the device to close, what type, what size, and you have running the risk of, more complications. What we learn is we need to use a very huge, not very huge, but at least large diameter of the catheter in order to deliver the good contrast, quality, and volume. We need at least 30 to 40 cc, and the pressure is quite important. You need to at least up to 700 psi, and biplane is much better, I would say. And don't forget the frame rate. Because sometimes when we deal with this adult patient, we usually tend to use the setting in adult PCI. So they usually use just 15 frames per second, which is not really enough for a very high flow on this situation. So reminding of this kind of thing. So in this case, actually, even if we try our best, but it didn't work, so then it comes to an issue of how to do balloon test occlusion. So the benefit on this will be you can get a better profile of the anatomy. You have more understanding of the physiology as well, because you can measure the pressure at the pulmonary artery side before and after balloon occlusion in order to get to the decision making that whether this is closable or not. Just to show you that sometimes with this kind of very confusing anatomy with the balloon in. So this is the Admiral balloon. As you can see, we can use either ASD sizing balloon or just balloon angioplasty catheter. And it's usually important that once the balloon is in, you need to check whether it's nearly complete occluded or complete occlusion of this is defect or not. And then you can decide by the width of your balloon whether what size of the device you're going to use. And again, the beauty of the test occlusion, not just to emphasize on the diameter or the anatomy, but also the physiology. So as you can see, with the room air, the PA pressure and aortic pressure looks pretty much the same. But after you occlude the balloon, it's getting lower on the pulmonary artery pressure. But after you giving the oxygen and also iloprost, the PA pressure is dramatically decreased. So this kind of thing that's showing that the physiology of the pulmonary vascular resistance is not really irreversible. So in this case, you need to discuss what to do, as Dr. Bharat Dawi mentioned yesterday, that this is quite challenging. But if you have a good intention to treat this patient with a good follow-up, and then you can have a good result. So this patient, we prime with sildenafil for 6 months before the procedure, and then we test occluded, and then we implant the device, and then we continue sildenafil until now, and we do zero follow-up PA pressure. And I won't say lucky, but I think we are expecting this. Most of the case, as Bharat mentioned yesterday, that this PA pressure is likely to decrease, but not come to normal. And also very simple lesion, ASD Secundum. So maybe if you are adult cardiologist, you may feel that this is very easy to close, right? Very good rims, just not, it's not a big one. But if you look at this carefully, you can see that the shunt is not really left to right. It's partly right to left, here. So for the small lesion like this, you need to be very, very careful before you trying to close it. Why? I will show you later on. So the hole looks small, but the patient has significant symptoms. So what happened? You need to think about high LV EDP of this patient. Maybe the left ventricle is having a problem on diastolic function, or they may have a problem on the left side heart disease, something like obstruction on the left side. So in this patient, we put the catheter into the left ventricle, measure the LV EDP, it's about 18. Well, not that bad, but not normal, definitely. And this is very important. When you deal with this kind of situation, you need to do test occlusion. Why? Because if you properly carrying enough in terms of the physiology. So this is before balloon test occlusion, and this is after balloon test occlusion. So as you can see, the EDP increased from 18 up to 32. So it's very definite. If you close this, the patient may run the risk of diastolic dysfunction on the left ventricle, and the patient may develop left heart failure or acute pulmonary congestion. So in this case, we decide not to close it, but we try to treat the LV diastolic dysfunction first and then come back again 6 months later or so in order to see whether can we close it or should we close it or not. And how about VSD? Again, this is common lesion, but once you found this in adult patient, it's not always simple. As you can see, this is very huge perimembranous VSD, 12 millimeter. Luckily, the peer pressure is not that high. So we do as routine, we cross it, we do a loop, and then we just recheck it once the catheter is passing through. And then eventually, we can use a very huge muscular VSD device, 16 millimeter, in order to close this percutaneously without surgical treatment. Well, again, it's not feasible in all the cases, but just to show you that sometimes it's not that easy, and sometimes this is also the thing that we can consider to do. And also, I don't know in your country, but in my country, we still have 40 years old man or girl, lady, or 60 years old with severe valvular PS like this. So as you can see, very, very severe. And once we measure the diameter, it's about 18 millimeter. So you can imagine that if you're going to treat this 18 millimeter annulus, you need to plus at least 120%. So it means that you need a very huge balloon. And last valve annulus, high RVSP, so inadequate balloon dilation is leading to the residual shunt or whatsoever. Arrhythmia may horse, and suicidal RV can be a detrimental problem for this patient. So again, we borrow the balloon from our adult colleagues. We use Inoue Balloon for the PBMV in order to treat this patient. And the beauty of this balloon is you can increase the diameter ranging from 22 to 26. So you can start with smaller one first, and if it doesn't work, you can increase up to what the nominal diameter that you really need. And this is before and after balloon dilatation. You can see it's very, very, very nice treating of this severe valvular PS in very huge annulus. But sometimes when you're dealing with this plastic valve annulus and also a very severe obstruction like this, you may thinking about using double balloon. Why? Because you cannot with double balloon you will not completely occlude the flow. And with the very hypertrophied and a very dysfunctional right ventricle, this may allow you to have a good result. And again, this is not one shot. You need to serially treating this patient little by little. You can't do it just completely abolish the gradient at one time, because that may lead to the complication to the patients. So how about complete untreated complex lesion? As you can see, so this is what we did in India a few years ago. So this is interrupted aorta, definitely, 34 years old. So with this, a catheter intervention can be done, but question to be answered would be like, is it feasible? How can I do perforation of this, and what's next after perforation? How to contain the complication, something like that. So eventually, we managed to put the wire from below to above, and then we rail lower it, and we put the stent mounting with two balloons, one into the ascending aorta and then one into the subclavian in order to avoid gelling of the subclavian artery here, and then eventually you can get a good result of make it a good flow from the above to below without gelling of the left subclavian artery. Or sometimes in my country, we're still dealing with very hypoplastic right ventricle, 40 years old, and very severe obstruction of the primary valve. So definitely this patient, we can't improve the RV size because she's 40. So we have to think what should we do. So in this case, they may have the debate whether if we balloon and peer pressure may increase, or we should go for just Promphan immediately. So again, multiple choices, and unfortunately we don't know the answer. So in this patient, we decide to just balloon angioplasty, but just using 90% of the valve annulus, so not much dilating, but saturation improved from 75 to 89. So again, sometimes with this adult congenital kind of complex lesion, we cannot aim to get very perfect result, but at least we need to palliate the patient and trying to help them in order to get to what should be the most suitable condition for them. Or like this patient, this is the first time I have seen the patient with the hoarseness and differential cyanosis. So you can imagine, because this patient has very huge MPA, and it's maybe compressing the recurrent laryngeal nerve, and that's causing very, very bad voice, but also the very high peer pressure. And once we put this patient into the cath lab, as you can see, not a big ductus, but it's bidirectional flow and quite significant coarctation here. And here is very huge pulmonary artery, main pulmonary arteries. So again, it's not written in the textbook what to do with this kind of patient. So you need to think whether should we leave her alone or send for surgery, send for coarctation repair plus kosher VSD, or doing heart lung transplantation, which is not easy because how can you tackle with the coarctation? Or we tried stepwise therapy. We stent coarctation first, and then we close VSD later. So this patient, we decide to close the coarctation, close the VSD together with coarctation by using the covered stent. So it immediately looks very nice. So we hope for the best, but unfortunately 6 months later, we try to recath the patient again, but the QPQS and PVR is not improving. So we decide not to do anything but giving medication, like giving sildenafil, and just treat her as we can do, as much as we can do. But again, this can be happen, and sometimes it's not really know what to do or how to do. How about post-repair congenital heart disease? As you may know that LPA stenosis is quite common, especially post-repair TOF. So you may argue that this is not really a big issue because, the flow can go to the right side. But again, there's very good demonstration of once we tackle with the branch stenosis, the regurgitation fraction decrease, and that is the thing that we need to think about. So in this case, we bring the patient to abolish the gradient here, put the stent in. We dilate it at the proximal to flare, the proximal part properly, the coda balloon, and then this is the final result. And again, in the future, probably, if we can do percutaneous valve implantation in this patient, that would be the good non-surgical option. So it doesn't mean that we don't need surgery, but we're trying to work together and think what to do for the best option for this patient, for the particular patient. And this is the post-TCPC patient, just to show you that in this patient, actually, the saturation is 85 because there's a fenestration, but it looks a little bit hypoplastic on the left side. But once we do pullback gradient, as you can see, the gradient just 1 millimeter of mercury. So again, somebody may say, well, it should be okay, but I would say that 1 millimeter mercury different pressure is quite important for the small, low pressure system like this. So eventually we decide this patient to put a stent in, and just to show you that immediate after the procedure, the saturation increased up to 90%. So again, this is what you need to think when you deal with adult congenital heart problem, whether what should we do or what should not we do. So just to conclude, ladies and gentlemen, that adult patient with congenital heart disease is not a big child. So you need to decide individually, depending upon the anatomy and physiology. You need to use not just very fancy kind of investigations, but examination properly, chest X-ray, ECG. This is also helpful. You need to use all modalities in order to decide the specific decision making for each particular patient. Test occlusion can be very helpful when you deal with a shunting lesion. And to my experience, I usually go for treat then repair rather than repair then treat. And you need to work in a comfortable atmosphere, definitely. Biplane is giving more room to help your idea how to see the anatomy. You need a proper angiographic techniques. You need the right instruments, and 3D road mapping is quite helpful at the moment, especially in the particular specific lesions. But you can't rely on only what's written in the textbook, because sometimes you need to write your own textbook. And it's about collaboration. You can't do it by yourself. You need to have your adult cardiologist, supporting you. You need to have very good surgeon supporting you as well in order to get over this. And as Forrest Gump said, that life is a box of chocolates, so you never know what we're going to get. So hope for the best and prepare for the worst. Thank you very much indeed.